Thank you so much for joining. And, I will try to kind of inspire you today to kind of think about your joint health a little bit differently. And particularly because we truly are at a time now in hemophilia where we should focus on joint health. And I'll explain to you why in a minute. Um, so, hemophilic arthropathy, and it's also abbreviated as HA. Really, it's the big name of joint disease and hemophilia. So you all know that with hemophilia, one of truly the largest problems and the causes of morbidity or disease or problems with patients with hemophilia is joint disease, repeated bleeding episodes into the joint. So we all know that prophylaxis is the standard of care for patients with severe hemophilia, and obviously with patients with inhibitor, prophylaxis becomes a problem. And so you have to do bypassing agents, which obviously do not provide as good of hemostatic management as giving back what you're missing. But despite institution of prophylaxis, believe it or not, Dr. Shapiro and Dr. Marilyn Minko Johnson, both of them pediatric hematologists, worked together on a joint outcome study where they looked at patients who received prophylaxis and those who didn't. And lo and behold, despite institution of prophylaxis early on, and when we talk early, so we usually start prophylaxis around 1 year of age, and it can be sooner if they had any joint bleeds. Back in the days, we used to have to put a port in and start the prophylaxis. Now there's other options with the non-factor therapies like emicizumab or Hemlibra. But as you can imagine, we're starting very early compared to some of you and what you've been exposed to or what other older generations have had to deal with. But despite starting early, despite everything that we're doing and really good amounts of factor available for patients, they still have joint disease on imaging and also by symptoms as well. So now, when we try to understand why is that the case, do you guys want me to admit there's somebody, I think, in the lobby?
I'm trying to figure out who that would be.
Yeah, it's a PNW. Yeah, I'll leave it up to you guys, but I wasn't sure if you could see it since we're sharing the screen. So one reason why we think that is happening is we truly don't quite understand why hemophilic arthropathy happens. And we also still believe that hemophilic arthropathy or joint disease in hemophilia of patients with factor VIII deficiency is different from factor IX deficiency. And it's also different from the hemophilic arthropathy that happens in other bleeding disorders like severe type 3 von Willebrand disease. So really, one of the big pushes that we're trying to work towards in our field, and one of the gaps that we have, is what you really want to do is you don't want to diagnose joint disease once the joint disease is visible clinically, right? We don't want to wait till Eric is limping and he's having trouble walking to say, oh, Eric, I think your knee is having a problem. You want to diagnose it in an early or a subclinical phase, because we believe that the earlier you diagnose it, that there is a higher chance that it might be reversible. And I say it's a belief at this point and a hypothesis because it has not yet been shown or proven that it is actually a reversible pathology. So what happens in joint disease and hemophilia? So, this is an example of a joint. So let's say that this is our knee and we just removed the kneecap. So this is the long bone of your thigh. This is the long bone of your leg. So these two bones, when they need to come together, in order for them to glide, you would have cartilage, and this cartilage allows them to glide. And then there's also tissue, fluid. This fluid is like a lubricating fluid, kind of like hinges, and having to put some oil or lubricating fluid. So this lubricating fluid is produced by this thin membrane, which we call the synovium. Okay. And so what happens with hemophilia is the bleeding occurs from this membrane right here, and the blood accumulates in the joint, and progressively it starts damaging the cartilage and the bone. And you kind of get stuck into a cycle, which is a vicious loop, because more blood makes this tissue thicken, and there's more chances of bleeding and getting that tissue pinched. And I'll show you what I mean. So, who, like by show of hands, who all have experienced, dealt with an acute hemarthrosis in the past? Yep. And so, with an acute hemarthrosis, quite painful, right? It's swollen, it's warm, it's painful. Usually, if you give factor therapy or a bypassing agent, you would be able to get the bleeding under control. The thought is that if you have an acute bleed, just one bleed, and you manage it properly and aggressively and upfront, the hope is that you go back to being normal. What happens when you keep bleeding is that this tissue that we talked about, this synovium, thickens, and then it thickens some more. And so you start getting those boggy joints. And as you see, this thickened tissue almost has like these finger-like projections. Sometimes they call them grape bunches. And these can get pinched between the bones when somebody's moving. And so it becomes a vicious cycle. Pinch, bleed, thicken more, pinch, bleed, until you end up with loss of bone and cartilage. So with acute hemarthrosis, these are some of the things that patients describe. You've probably been through them. It's a very small space and it's under pressure. So you'll get that bubbling, that prickling or tingling sensation. It's extremely painful. Your joint becomes stiff. You can't move it. Sometimes the muscles around it tense up because of that. And then if the acute bleeding happens and then you treat it, subacute bleeding can happen in that phase when you're recovering from your initial bleed, and then maybe you went back to physical activity sooner than you were cleared, or you thought you were okay, but not really. And then you start bleeding again. So what happens with subacute hemarthrosis is that you're really not giving your joint the chance to heal. And eventually what we don't like to see is these big boggy joints that have two problems. One of them is excessive amounts of this very bloody tissue, so to speak. It's very vascular. It'll get pinched and cause bleeding episodes. But then the other thing that happens is you lose all that cartilage. So you end up on bone. So this is really what we see in hemophilia without prophylaxis, hemarthrosis, and then you get into the stage of the soft tissue. And then when you look at the x-ray here, so the white is the bone, the black is the space in between and the cartilage. And you see here, you lose that space and it's literally bone on bone. And this is what the cartoon would show you with this, thick tissue, and then the loss of the fluid in there, loss of the thinning of the cartilage, and then destruction of the bone. I'll tell you right now, what we don't know is this. We are trying to investigate and see if we can reverse the soft tissue component or the swelling of this soft tissue, but we don't really have very good evidence that if you progress towards the bone damage or you lost the cartilage, that we can get that back. But, science is changing, the medications are changing. Could that become our reality one day? We don't know, but we hope so. But I'll tell you, the hemophilia joint disease is very different from rheumatoid arthritis, because when we look at babies or children with rheumatoid arthritis, if you treat their rheumatoid arthritis, they get reversible changes. Some of those joints go back to normal, especially in kids, because they have a good regenerative ability. But we're not really seeing the very damaged joints in children with hemophilia come back to being completely reversed. But time will tell. So then some of the problems with chronic hemophilic arthropathy or joint disease in hemophilia, and as you can imagine, that's why it's such a morbid condition, this really affects their range of motion. It's painful to move. Their quality of life is not good. Their occupation are not satisfactory. They start gaining weight and developing complications related to hypertension and obesity and high cholesterol. Besides that, particularly factor VIII deficient patients, we see a lot of problems with low bone mineral density and osteoporosis, which puts them subsequently at risk for fractures. And so there's a lot of issues that can happen when that joint is very arthropathic. And so what you don't want to try to get to is a target joint, right? So target joint is a joint where you're constantly bleeding, you're losing muscle, your joint becomes unstable, you grow this soft tissue, you develop the synovitis, you pinch it, you're bleeding, and the cycle repeats and repeats and repeats. And I'll tell you, one thing that I always tell my patients, and that's something for the mothers in the group, moms do such a good job. They give the prophylaxis religiously all through their childhood. Then they become teenagers and they start getting that feeling of being invincible, right? And so I always tell my teenage boys, I tell them, listen, your mom did her part. Now it's on you. Your joint is the biggest investment of your life. Keep them healthy so that you can live a life with good quality for longer. Because sometimes people think that you really need 25 or 30 joint bleeds in order to damage a joint. And that's not really the case. Sometimes you can have the highest number of joint bleeds I've heard of was in a mild patient actually, and he had 25 joint bleeds within a year in his elbow, and his elbow completely got destroyed. And it was because he was refusing to listen to medical management and the directions from, and he was a pitcher. So he was a mild hemophilia patient pitcher, would keep resuming physical activity, bleed, go back into that vicious cycle. So it doesn't take a lot to damage a joint. So it's not meant to scare you, but it's meant to remind you, treat early, be careful, invest in your joints. What you lose, you might not be able to get back. So now you know some of the push right now from industry and the field is to evaluate the joints better, right? Because we have gene therapy, we have non-factor therapies, we have all these different types of factor products, some that are extended half-life, some that are short half-life or regular half-life. And then you look at them and you're like, okay, well, how do I compare them, right? So we want something that is deeper than just looking at the person and saying, oh, they look like they're okay, they haven't reported any bleeding, to say that their joints are truly protected. And so there has been a lot of evolution in how we evaluate joints. One of them is, you come to comp clinic or joint health clinic and the physical therapists bring their tools and they start doing all those range of motion measurements. They look at your muscles. So these are clinical assessment tools. Furthermore, we use x-rays, and I'll explain that in a second. And then we have the very expensive MRI, and I'll show that in a second. And then we'll focus on why did ultrasound gain such traction in the last 5 to 7 years. So when you look at x-rays, the problem obviously is this. You're not really seeing much, right? So you look at the x-ray and you see the bones. You can evaluate fractures, you can evaluate loss of cartilage, you can evaluate bone destruction, but the problem with x-rays is it's limited to very late changes, right? And so you really want to figure out the changes in the soft tissue or the synovium or any evidence of blood in the joint sooner than getting to this stage and saying, oh, we missed a knee bleed, right? Or repeated knee bleeding episodes. So that is the problem with the x-ray, plus it's radiation. But it's obviously not as concerning as a CT, which is about 100 x-rays worth of irradiation. The issue with MRIs, I describe it exactly like taking your car to the repair shop, right? So you get it in your car in the morning, your car starts making a noise. You know that you've had this car for 10 years. You know that, the AC doesn't work and the rear mirror is broken and the front tire has this problem. You take it to the repair shop. You just want to answer one question. What is this noise that started this morning? If you want to put it into perspective with a patient, let's say we have a 50-year-old, he knows that he has a bad right knee. It's caused him problems all his life, but he woke up this morning and it hurts and it's more stiff than normal. So all he's looking for is, why does it hurt today? And why is it more stiff than normal? And so what the MRI does is, just like when you take it to the actual dealership, right? They're going to run a full report and tell you everything that you know. It's a comprehensive 360 evaluation. It's not really a good tool to be able to say, just answer a yes, no question. What is going on today? And so that is the problem with MRIs, but they have a lot of advantages. They are multi-tissue. We're looking at bones, we're looking at cartilage, we're looking at muscle, we're looking at meniscus, and so on and so forth. They are good to evaluate very early change and also very advanced change. It is the gold standard, but it has problems in children, right? Because we need to sedate them. You kind of can do 1 to 2 joints at a time, not more than that. But I will tell you, I am partnering with a group of researchers in Canada, and they're trying to do a whole body MRI. So like they would basically put the hemophilia patient in the scanner, and they're hoping that within 15 minutes, they can get a lot of questions answered about both elbows, both knees, and both ankles. But that protocol is taking time to finesse and be able to do. But if they get that, that's going to be awesome. So that's a whole body MRI technology. MRI is not radiating, so it's pretty safe if you can sit for the duration of that and not need sedation. The problem with it is currently the current MRIs, they take a lot of time. The patients are not going to feel comfortable sitting there, especially if they're pediatrics. They are high cost. And if you have a joint that is kind of, stuck in a certain position, they're not going to be able to put you in the MRI scanner, which makes a lot of people claustrophobic in a comfortable position for you. And just like we said, something that is so expensive, it's not really good for follow-up, right? And so you're not going to be wanting to do it every month or every 6 months. You're going to want to do it when you really want to answer very important questions and you want a very comprehensive evaluation. So when you have a tool that is so expensive that you can't do very frequently, unlike your exam or our stethoscope, when we listen to the patients every time we see them, you may miss early changes between those two time periods when you're going to do that big study. So this is kind of why all of those gaps between x-rays, clinical exam, and MRI is why ultrasound came to life. So what we started noticing is that, if we wanted to look for the earliest evidence of joint disease and hemophilia, we know that it happens in joints that are either symptom-free or almost symptom-free, and so you would be able to use the ultrasound for that. It has excellent spatial resolution, and you can scan the joint at different ranges of motion, right? So if the patient is stuck in his elbow and he can't bend it more than this, that's fine. You'll accommodate. You'll put more gel. You'll push harder on the scan. You will, be able to move his joint slowly, or your ultrasound probe to accommodate. You don't need sedation. It's very available. It's portable. You can carry it in your pocket. We have ultrasound machines now that look like cell phones, it's also low cost and does not have any radiation. It's not painful at all, and it is very minimal harm. The only thing I've ever heard anybody complain about, there were 2 kids in the US, one in our center and one in California, I believe. They were both autistic, and interestingly enough, both of them, they reported the ultrasound to be hot. Ultrasound does actually work on sound waves and vibrations, which kind of speaks a little bit about, with autism, like I've always felt like they have kind of super sensory. So both of them reported it as hot, which was very interesting observation on both of their part, but almost everybody else does not feel much. If anything, they complain of the gel being cold. So, and another thing I actually want to let you know, if any of you have family members that are now going through medical school, so point of care imaging, meaning imaging at the bedside with ultrasound, is now being part of training for medical students. So if they are going to work in the ER, they're going to train them how to do ultrasound of the abdomen. If they're working in the ICU, they tell them, hey, your stethoscope can only take you so far, use an echo to look at the function of the heart. So ultrasounds are being implemented in medical school training as an additional tool besides our hands and our eyes and our ears. So what is the difference when you talk about ultrasound with your hemophilia provider, right? So a lot of centers, when you talk ultrasound, they're going to think you're talking about full joint. So a full joint ultrasound, you're going to go to the radiology department. They're going to give you an order. You go to your radiology department. They're going to do multiple planes and evaluate you. And not all hospitals are actually fully equipped with technicians who are familiar with joint scanning, because joint scanning is quite difficult. Point of care, on the other hand, is no. At your HTC with your hematologist, you're sitting next to them, they pull over an ultrasound laptop machine or an ultrasound probe, they put it on your joint and you scan. We don't even pay for it. And they can do it at every visit, whether you're having symptoms or no symptoms. The issue is this requires a lot of training, and you have to understand that you're doing specific planes to try and answer specific questions. Bleed, yes, no. Joint disease, yes, no. Cartilage is good, yes, no. Bone is damaged, yes, no. So you're answering very specific questions. You're not doing the whole thing. And that disclaimer is very important, because a lot of times I get my patients, they come to clinic and then they go to ortho and they say, well, Dr. Bakeer scanned us. And then the ortho will say, oh, okay, so if it's normal, then it's normal. And then they will tell him the disclaimer that I say that no, Dr. Bakeer went in there, did just a few scans looking for bleed, no bleed, this, that. So that makes them think, oh, okay, so she wasn't really looking for fractures. She wasn't really looking for, God forbid, tumors, So you have to understand that limitation because you don't want your patient to be falsely reassured. So if the ultrasound gives you answers to the questions you have, great. If it doesn't, you need to remember you got x-rays, you got CT, you got MRI. So I'm going to pause here for a second and see if anybody by show of hands has had experience with point of care ultrasound. So got scanned themselves. So somebody gets scanned in an ER. Okay, so I see Kevin, James, Eric, Chris. Point of care, kind of at the bedside. Okay. That's cool. That's more than I expected, actually. So, University of California, San Diego, Dr. Von Drgalski, one of our collaborators. So she did a study where they told their patients anytime they had a joint or muscle pain to call. And so they evaluated 40 episodes in 30 adults within 48 hours of the symptoms. And they had their physicians examine them first and say, hey, what do you think is going on? They asked the patient to tell them what do they think is going on. And then they scanned them with ultrasound. And so the patients in 33 out of the 40 episodes, they said, I'm bleeding. 100% I'm bleeding. I already infused. 5 out of those 40 episodes, they said, no, I don't think I was bleeding. I think I just have a flare up of my chronic joint disease. And 2 cases, the patients were like, I'm not 100% sure if I'm bleeding. Maybe it's a bleed on top of my joint disease. And then when they went and did the ultrasounds, they actually noticed that only 12 of the 33 episodes where the patients were infusing were actually bleeds. And 3 of the 5 times when the patients were not infusing were actually bleeds. And so what you come to realize is that ultrasound showed them that the patients and the doctors were correct about what was going on with the joint in only about a third of the episodes. And that's kind of disappointing, right? Like you go to med school and it's your body and you guess it right only 30% of the time. And I think this study in particular has made me use ultrasound for a different use, really, which is biofeedback. So when you talk about biofeedback with your patients, what biofeedback is it's trying to get the brain to connect with the part of the body that you're focusing on. So I usually use the ultrasound when my patient comes in with an acute painful episode. And I sometimes let them touch it and play with it and tell me where it hurts the most. But over time, what happens is the body starts making these associations of that day I felt like this and I had a bleed that I confirmed on ultrasound. This day I don't feel that much and I didn't have a bleed on the ultrasound. You start making these associations of how do you feel and what is going on with your joint. And it also allows you to have a deeper understanding of what's going on with your joint. So what does the ultrasound look like, right? So we started back in 2015. So I joined the IHTC and I was tasked with starting this team. Dr. Hardesty helps me out from an adult. He's an adult hematologist. And then I'm blessed to have 4 amazing physical therapists. So this is the core team. We're the ones who do all of the scans and we meet regularly. But our team itself is about 15 people because we have IS specialists, people from also the information systems, technology, admins, and so on and so forth. As you can look, we've gotten a ton of training, right? So there's 2 big training groups in the world. One is in Italy, Dr. Martinoli, and the other one is in San Diego. And we knew we needed a lot of expertise. And every year we made sure that we went to a course and we learned. In 2020, we actually taught multiple centers virtually. And in 2021, we did the same because, you see one, you teach one, you see one, you do one, you teach one kind of concept in medical education. So how do I look at ultrasound in hemophilia? The first thing we kind of alluded to, you come in and let's say James came in, woke up in the morning, he's like, man, my right elbow's stiff. I can hardly bring it all the way out. I feel some bubbling, it's warm, it's bothering me. Am I bleeding? I feel like I'm bleeding, but I'm not sure. So you're trying to come in to evaluate a painful musculoskeletal episode to answer a yes/no question. We'll talk about the other causes and the other uses in a second. So he comes over to our clinic and we decide to scan. Okay, so this is a knee, and this is where so with ultrasound, everything is shades of gray. So white would be your bone. So I can try to annotate here for you real quickly. So this would be your thigh bone. Right here, you would have your kneecap. And then this is a fat pad. And this is another fat pad. And these fat pads normally touch and they glide on top of each other, allowing your knee to flex and extend, okay? But what you can see here is there's all of this in between those fat pads in that joint space. And so when you put the ultrasound probe on it and then you start moving, you can see all these tiny, tiny little speckles. Do you guys see that? Like almost like sequins inside the joint. So what that is, these are actually the red blood cells in blood. Those red blood cells in blood, they are reflectors of the sound waves. And so this is an acute hemarthrosis. We're saying this is a hemarthrosis, may have infused for or not yet, has happened within 24 to 48 hours. There's a lot of liquid blood in there. There's no blood clotting happening yet, okay? So let me remove the annotations. Okay, so now, you know, when you look at an MRI, or has anybody ever looked at a blood in a tube and how the blood separates into that plasma and serum up top and then the red cells at the bottom or the blood clot? Believe it or not, if we had James sit on the table for a little bit and we went to order labs and other stuff, we come back, we're going to see the same thing on ultrasound. So there's going to be that clear liquid up top, and then all of those sequin or speckled blood cells, they kind of sink down. If I get him to move his joint, things will mix up again. So it's pretty neat and it's very easy to see. After a while, you know, James went home, we gave him factor or we gave him bypassing agent. He comes back and we have these. These are blood clots, no different than blood clots in the tube. You will see blood clots in the joint. So they're bizarre shape, they kind of clot down. And the ultrasound is pretty cool because when we see this, we know that this is a blood clot. But when we see this, these little bunches of grape, do you guys remember what we said was those bunches of grape on that cartoon, that soft tissue synovium, the red thing? Let me show you here. So it's this guy right here. Let me do this. So it's these little finger projections. Oh, it's not liking me doing that, huh? It's in the cartoon, those little finger projections, the red things, you know, the ones that get pinched. So that's exactly how they look on ultrasound. You can actually wiggle them, you can move them, but you can imagine these things just dangle down. You move the joint, it's going to get pinched between these two bones. Does that make sense? How you would be able to see that? And I'll tell you, with time, by the end of the talk, you guys are going to notice on your own that it's quite easy to make out what is going on in the ultrasound. And my teenage boys actually figure it out pretty quickly if they've gotten scanned 2-3 times in a row. So let's go through a couple of cases. So, you know, this is an 8-year-old boy. He has mild factor VIII deficient hemophilia. He banged his knee on the bed frame, and he came with right knee pain swelling, and he couldn't move his knee. So now, you know, you look at him, and this is the picture that the mother sent and gave us consent to show. And this is how swollen his knee was. I mean, by just looking at this, who here would say that it's a joint bleed? Yeah, right? You're like, looks like a duck, quacks like a duck, it's a duck, right? And so mother was very sad actually, because he's a mild patient, and she's like, man, like a little bed frame bang, and we got our first joint bleed. And you know, so we scanned him. First, we started with his normal side. You remember that's your kneecap, long bone, your fat pads, and there's nothing in the joint. You don't see those little speckled sequin looking things. And then you scan his other side and you're like, here's his kneecap, here's his long bone. There's really not much between the fat pads. So I was like, oh, this does not look like a joint bleed. And look here, all of his bleed was actually above his joint. It was all in the soft tissue, all around the joint. And so the ultrasound was very helpful to identify how extensive his joint bleed, bleeding episode was outside the joint. Now, did it change your management in terms of did you give him factor therapy or not? Of course we gave him factor therapy, but this is not a joint that we have to worry about developing joint disease in the future because the joint was fine. All of the bleeding was outside. Another example is this boy. So this boy was an 11-year-old. He has severe factor VIII deficient hemophilia, and he was on a longer acting 4th generation factor VIII concentrate. We know he has a left ankle target joint. You know, he's always had it. We know about it. So what he did is he tripped on a toy and then called immediately because he swelled up, and he did 3 doses of factor, 1 major dose a day for 3 days in a row, but he was just not feeling better. So he came to clinic. So, you know, the cool thing about doing ultrasound is we know what he normally looks like, and we were able to compare how he looked like today compared to the past. So here we're scanning the ankle. So this is your foot. We're right on top of the ankle joint, okay? And so that's your shin bone, your long bone of the leg, and this is your ankle joint. And these are those little finger projections. Because it's a target joint, we know that it's not perfect. We know that he has soft tissue. But you look at him, how he was before he tripped on a toy, and then you look at him now, and you notice that the joint space just got pretty swollen. And you can imagine such a small little place having this much amount of blood and soft tissue and pressure in it, and how painful that can be. And so you see here, this is another way that we look at the joint. We flip our probe, so we're looking at it horizontal instead of longitudinal, and you can see normally just a little bit of that soft tissue, and now with the bleed you can see how much blood is in there. The issue is, what we noticed was when we treated him, we gave him multiple days of factor in a row, and then we told him to calm it down and not get back to physical activity. He went back to physical activity quickly, and the joint was not stable, tweaked it again, and then started bleeding again. One reason why you're very vulnerable if you have a target joint and you get a bleeding episode is because when you bleed, what we notice is that you see how, like, you say your joint is on fire. So these little flames are actually the blood vessels of irritation of the joint. And if you just bled, those blood vessels kind of flare up. So if you've ever had a bad joint bleed and they put you on steroids, anybody ever went on steroids for a joint bleed? So what they're trying to do is simmer down this throbbing, this irritated, angry joint. And what causes this irritation and angry joint is all of this increased blood flow to the joint. So you can imagine you have a bleeding disorder and you bled, and now your joint is on fire, it's irritated, and then you bleed again, right? Because it's already very inflamed and irritated. So that's what we've learned from ultrasound, is it's actually very important to try and avoid returning back to activity early when you're in this phase. When on power Doppler or on evaluation of the blood flow, you notice that there's a lot of blood flow in the joint. This goes back to calm down after a while, like we would say, like about 3 to 6 weeks after a bleed. Another example of why we use ultrasound is to look at muscles. Has anybody here ever had a bad contusion in a basketball game, knee to thigh or elbow to arm or anything like that caused a bad muscle bleed? Looks like he's had one.
Bad muscle bleed, but not from basketball.
Yeah, what was it? Do you mind sharing?
Oh, I used to get some bad calf bleeds and thigh bleeds, just kind of out of the...
Yeah. So, you know, when you look at him with ultrasound, so this is a thigh of a boy of ours, and this is the femur, so your thigh bone. And then what happens with muscle bleeds is usually, especially if it was a crush injury or an impact injury, is the muscle that gets most that has the most problem is usually the deepest muscle. So this is the skin, and then this is the top muscle. It looks okay. This one looks like it got affected, and then you can easily see this bleeding, massive bleeding inside this muscle. And This takes a very long time to heal. So this boy, and Kevin is nodding yes, it takes a very long time to heal. It's a lot of pressure inside this muscle. And so this boy needed to actually come in on a factor drip, and then slowly, slowly the blood starts fading away and disappearing. And sometimes, unfortunately, what happens is that muscle scars down, and that becomes you start getting stiff a little bit in that muscle. You don't have great range of motion, and so then if you don't do adequate stretching, you might get hurt again and bleed from that area of the scarring.
Yeah, some of my calf bleeds almost developed into pseudotumors from
Yep.
And actually ultrasound was used in a different way to kind of try to break up the periphery of the
exactly. Yep.
And in that case, it does get hot.
Yes. You know, that's similar to like when they use ultrasounds can sometimes be used to actually heat air bubbles or water bubbles, saline bubbles, to break down blood clots too. We use that. It's called ECOS.
Yeah,
it's awesome, Kevin. Very helpful. Thank you. Sorry you've been through all of that.
It's been a while. This was years ago.
Yeah. So you know what we've noticed when we started using ultrasound for this purpose is that we can go in there and say, yep, he looks like he has a bleed, and then realize that he has a bleed, but it's not really a joint bleed. So it's really helping us with our perception of and understanding what caused the symptoms. It allows us to have a beneath the surface look to be more accurate. We've also been able to differentiate what a first bleed looks like compared to a bleed that has happened in a joint that has bled before. It's monumental in evaluating muscle hematomas. And we've noticed that our therapy is changing. We're not just restricting it to factor or, bypassing agents. Above all, for me, what makes it most rewarding is how my patients learn from this, how the mothers learn from this, how convincing, a picture is worth a million words, right? You can tell them a million times, listen, boy, your joint is not ready. You should not get back on that basketball court. And until they see it, they will not know, right? And especially when you compare it to their other joint, it's just become such a good tool to allow them to be compliant and aware of what's going on. We loved the technology so much, we actually utilized, and these are available, by the way. So like Kevin, if you ever want to see what your calves look like, you go on Amazon, you want a Lumify probe there. They sell, I believe, for $2,000 to $3,000 now. They're probably going to start getting cheaper and cheaper, If you ever, do I see patients using them? Not gonna lie, yeah. And am I helping centers in the world to try and develop artificial intelligence? Yes, like we're trying to see if the robot can tell you, like, Eric, I think you are bleeding in your joint. Like you just put it on your joint and then the computer will tell you, yep, looks like a bleed. We're not there yet. It's gonna take us millions and millions of images for the computer to become smart. But we loved the technology so much, we invested in these and we gave them to our Amish nurses, because a lot of our Amish kids, they get, and the patients who live away from the center, we wanted them to have the same care that the kids in Indianapolis get. So we send them out to the house, they hook this up to their cell phone or their little tablet, and then they call us and I can see the scan, I can see the patient, and I can see the position of the probe in a 3-way video call. And it's been phenomenal to be able to do that. So now very briefly for the other two uses. So, ultrasound can be used to aspirate a joint. And you can see here, so these are the bunches of grape, and there's some fluid here. This black stuff is fluid. So you bring the needle in, and then you put it in the joint and you start sucking that fluid out. So you're going to see this kind of shrink in. So, one could ask, like, if I bled right now, should I go get it aspirated, right? I will tell you, trying to remember if it was the Italians or the Spanish. Sorry, we're a very small group that does all of this work. I think it's the Spanish. There was a study that was done where they basically told the hemophilia patients, 16 and older, anytime you get an acute hemarthrosis, come to clinic, we're going to suck that blood out. And they sucked it out, and they noticed that the patients needed less factor products, and they resumed physical activity faster, and their symptoms got better faster. And so would I do this? Dr. Hardesty, the adult doctor, does. So we use it for adult patients for symptom relief, because removing that pressure really helps, you know. But also, if I have a patient who has never bled in his joint and all of a sudden falls, fractures, and gets a whopping bleed, I know what a big bleed is going to do. So I would encourage him to go, like for us to go in there with ultrasound, very carefully take that blood out. When we would do it is when the blood is very liquid, right? Because look at this, you want to be able to suck something out. You don't want to go in there and meet resistance and pressure. You don't want to go in there and dig and cause harm. It's a very clean approach. Go in, suck it out, and get out. And you have to be careful. You can't do it multiple times because you don't want to do an infection. We haven't implemented it in all of our patients because it's invasive, right? It hasn't been proven yet. There's a risk of infection, and I don't want to sedate my patients, right? But if it's a teen who will sit through it, he's in a lot of pain and it's his first time, getting that blood out, we have good evidence to show that getting that blood out will shorten their recovery time. Another reason.
Have you seen any problems from the trauma of sticking a needle into the joint?
No.
Does that cause more bleeding?
No. And you know, one thing that will happen is you do have to give them factor before. So you convert them into normal, and then you put the needle in there, suck the blood out, and done. You don't go in there and do this. The other thing that I will tell you is, can they rebleed? If you don't treat them adequately with hemostatic therapy, they can. Because have you guys ever heard of auto tamponade, when the bleed is so big that eventually it puts pressure and stops the bleeding on its own just because of how much pressure is in there? So sometimes taking it out, creating that negative pressure, could make you rebleed, but that's why you need to have given them good factor therapy, you know. So this would not be something I would do and say, hey, here's a factor and then go home. No, he's going to be on factor, you know, so that he doesn't rebleed. Other investigators have used this technique to put steroids. Some of them have put hyaluronic acid as a lubricant in chronic joints. And more recently, they've been using PRP, or platelet-rich plasma. You guys have probably heard it. They're using it in the face with plastic surgery and stuff like that. So like, I'll take Kevin's blood, I'll process it, I'll get the platelet-rich plasma, and then I'll inject it in the joint, with the thought that this platelet-rich plasma has a lot of good regenerative capacity to help heal the joint. But you're not using somebody else's blood, it's your blood.
Dr. Bakeer, I'm sorry to interrupt. I think Elvira has a question.
Yes.
Hi, I do. I actually had my son get his knees aspirated a couple times, more than twice. And both times he actually had severe trauma. He did rebleed.
He did rebleed.
And so maybe it was the inhibitor, or maybe, like you said, they didn't give him enough factor before, during, and after. But from now on, we say no.
No, right. For an inhibitor patient, I probably would not. So somebody that I would do it in would be someone that I can achieve good hemostatic management. The problem with inhibitors is, you know, is your son on what therapy is he on for the inhibitor?
All right. So with my son, Miguel, and he's not here. And unfortunately, you know, I wanted him to be here to listen to this, but he got an inhibitor at age 7. And after being on Benefix for about a year, good 2 years. And then all of a sudden, he just went to camp and his knee went like a balloon. And we went immediately to the hospital after camp. And sure enough, that's when they found out he had an inhibitor. And he was on rituximab, Cytoxan. We did that. But he has hemophilia B. And so right now he's 29 years old and he still has the inhibitor. We can't get rid of it for nothing.
And what is he on?
He's on, actually FIBA does not work for him. He bleeds into his kidneys when he takes FIBA, and he also tells me that he tastes the FIBA, and so he gets the allergic reaction to the FIBA.
Right.
So the only lifesaver is Novo 7.
Okay, so you know, there is a new medication. Where do you guys live?
So we live in Chicago area, so not too far from Indiana. So we're ready to come see you if you want.
I don't do adults, but I have a lot of colleagues who do. Why don't you write me? Because I do have the youngest hemophilia 9 inhibitor in the center, and I have him on a compassionate trial for a medication called concizumab. And it's have you heard of Hemlibra for factor 8 inhibitors?
Yes, I have.
Yes. So it's a similar non-factor therapy, and it's been life-changing for my baby. Life-changing. And I know that we have an adult on concizumab. So I just put my email in there. Just email me, okay? And let me connect you with Dr. Shapiro, our medical director, and let's see if we can help him out. Because Novo's half-life is only 2 hours. And so you need... That's the problem.
I can tell many stories, doctor, about that. We used to beg for PICC line, because it would be impossible to keep sticking him. And of course, he's got scar tissue and limited joint. But I must say that we were with Dr. Valentino, and so he's had 9 synovectomies with an hip.
Yeah, that's impressive, huh?
Yeah,
but
so walking.
I think concizumab, I think concizumab is your answer if you want my honest opinion. And they started it so they opened it for adults. They've had some good results. Then they opened it for compassionate use for children. And then I believe in early 2022, like the first quarter of 2022, they're hoping to open the pediatric study and not just on compassionate basis. But that would be phenomenal because factor 9 inhibitors are super troublesome with the anaphylaxis, the no good alternative agents. But I'm kind of excited to see what we can do. And we'll partner with your local provider, I'm sure. But just email me and let me connect you with Dr. Shapiro and the adult team, okay?
Great, thank you very much.
You're welcome.
If the efficacy of that is anything like Hemlibra was for factor 8, it was a life changer for me.
It's impressive. It's impressive. Kevin, are you a 9 inhibitor too?
No, I'm 8 inhibitor.
Yeah.
But I have been on Hemlibra since 2016. I was the second person on the phase 1.
Really?
Yeah.
That's awesome.
And game changer, yes, for sure.
Game changer. I mean, I can't even tell you. I mean, before my baby with the hemophilia B, I mean, I saw him get that severe anaphylactic reaction and almost lose him, you know what I mean, from that. And then he was constantly bleeding. He's teething, and we're having to do Novo 7's Q3 and Q4 and Q6 and weeks. And then we switch him on concizumab, and now he bangs his head and we hardly need to treat, like life-changing, definitely. So I'm very excited for your son. We just need to figure out the logistics, okay? All right, so I'll try to wrap it up very quickly for you guys. One thing that we are very good at and unique kind of in our center is that we do the surveillance imaging. So we follow joints over time. I'm not going to bore you with this. This is more the research component of this, but we basically look for the bunches of grape, that soft tissue. And we also look for loss of the black, which is the cartilage, so the bone on bone. We took the ultrasound everywhere, like whatever space you'll give us, we'll take it. We went in Indiana, north to south, east to west. This was a nursing home. This was my nurse's sister's house. We take our ultrasound machine, strap it up, and we go. And we scan and scan and scan. And then if the kids let us scan all 6 joints, they accumulate iScan awards over the years. And some of the things that we look at is, you can see here what a normal 5-year-old's elbow looks like, long bone of the arm, and this is the forearm. And then you can see what a 5-year-old with a target joint looks like with all that bunches of grapes in there that keeps bleeding and bleeding. And then this boy was actually a boy that they involved me in his care because they were like, he insists that he doesn't bleed and he doesn't need factor. And, this is what a normal ankle looks like, these beautiful bones, very crisp lines. And then he has the ski slope in the middle of his ankle. So I put it on there and I'm like, So you're sure you're not bleeding? And I showed him his right ankle and his left ankle, and he said, yeah, what is that? And I said, that's a bone damage. So you're definitely bleeding and you're definitely not infusing. So for him to just be able to see it, he was just able to believe it, you know, to believe that even though he feels okay because he's gotten accustomed to the pain. He's gotten accustomed to that being his reality. He's not really okay. His joint is not healthy. This was an inhibitor patient, so kind of Kevin, similar to you, you know, he has factor VIII deficient hemophilia, came to us, and he actually also has type 1 von Willebrand disease. He was missing 32 degrees of extension on his elbow. I mean, this boy came to me like this, you know, multiple bleeds in the joint. I won't bore you with a lot of the details, but you can see all of this result of the bleed, that thickening of the tissue in his elbow. You can see his right elbow is perfect, and then the left side is just full of that tissue. You know, we put him on Hemlibra, and I'll show you. He gets back almost full extension. You know, he's down only now 5 degrees. He can supinate, pronate. He has not had a bleed since the day I've met him. We've taken out the port, got rid of that. He doesn't do Novo, doesn't do FIBA, doesn't do anything, just the Hemlibra. And you can see how much the soft tissue has come down. So I know that that part is potentially reversible. The part where we know that is not likely to be reversible are the bone changes, you know. So when you compare his right side to the left side, you notice that the left side is a little bit irregular, you know, some early damage to the bone. So really what we're seeing is, if you're going to do those 6 joint ultrasounds, they take about 30 to 45 minutes to finish. We use buddy systems, 2 PTs or 1 PT, 1 physician to do it. It needs a lot of expertise. And scanning kids is very difficult because half of their bones are cartilage. So you need to be very knowledgeable. But really, all in all, like, what has the ultrasound done for us? It has done this great beneath the surface evaluation, and it has really improved both our understanding and our patients' understanding of joint disease and hemophilia. And as a group worldwide, we actually are collaborating to try and improve ultrasound's ability to detect bleeds and joint disease, and try to compare it to MRIs. Because while MRIs won't be available for everybody, if we train hemophilia providers around the state, then all of you would be able to get scanned when you need to. And usually this would fall under hemophilia comprehensive care, so it's free of charge. It's not an additional charge. You don't need to go to the radiology department. This is the International Prophylaxis Study Group, and you can see multiple members from around the world all working together to try and improve joint health and hemophilia. And this is the newest scanners. They look like a little handheld device. There was a study in San Diego where they took normal, you know, hemophilia adults, just like you guys, gave them a very short course, and then saw if they learned and were able to do that. And the results were actually pretty promising. And so I want to thank you, Eric, for inviting me. And these are our lovely physical therapists, Stacy and Tiffany. After they finished scanning one day in outreach, we were all together, and I took this picture. It's a favorite picture of mine. And these are my acknowledgements and my email for any of you guys if you have any questions.
We had one question come in from the chat. Do you have any recommendations for preventative ultrasounds? We worry about microbleeds in both of my sons, especially because they may be too young to tell us if something hurts. We don't want to have any surprises later in life if they have a scan and all of a sudden we see damage.
Yep. You are exactly hitting the nail on the head. So that is what the baseline scans is. So in our center, the minute that the kiddo is, so my youngest boy to be scanned was probably 6 months. Those are too early to get scanned, and he sat through it like a champ. But we usually start scanning about 1.5 to 2 years of age. We scan them every other year for all 6 joints. If they develop a target joint or they have problematic joints, we rescan that joint anytime they're in clinic for the exact reason that you're talking about, which is evaluate subclinical evidence of bleeding, so you intervene when it's potentially reversible. We don't want to wait until they're limping and they lost range of motion before we intervene.
Fantastic.
So do you do you follow at the IHTC or where? Montefiore. Okay. Yeah. Yeah. Do you, I'm trying to think who all is in Montefiore, if I've trained anybody there.
Dr. Mitchell.
Okay. Yeah. Yeah. Okay. Yeah. Not everybody is trained in point of care, but at least, you know, my dream is if not everybody can learn to do the point of care, at least teach the radiologists how to do it. So they can send you for a point of care at the radiology department, get all 6 joints, give you a report once a year and be done, you know. But we're getting there. Yeah, we're getting there.
Yeah, I know up in the Northwest where I am in Portland and Seattle, they're doing that a lot. Bruno, I saw him on your collaborators, Bruno Steiner and Dave Olson in Oregon.
You know Bruno?
Yeah, I know Bruno, yeah.
Oh, I love Bruno. He's the most animated person in the world.
Yes.
I love Bruno. Bruno and I were talking on Tuesday because once a week we all collaborate, share images anonymized, but we basically brainstorm ideas on how to help patients. Yeah.
Yeah, he's done some. I coordinate the Blood Brotherhood with the guys up in the Pacific Northwest. So he's come and done kind of showed us what it's all about. And
yeah, he's awesome. I love.
Yeah,
Bruno.
he's great.
Yeah. Any other questions I can answer for you guys?
So Dr. Bakeer, this is actually my first, you know, presentation I've actually seen or witnessed, and I just want to say it's pretty fascinating. I appreciate your enlightenment. I was kind of curious though. So you feel like the readings and the results are pretty accurate? They've never had any misreadings really in your expertise?
It's a learning curve, Eric. You know, in ultrasound, we always say the more you know, the less you know. But I'll tell you what I've told the physical therapist. So when we first started, it was quite intense. You know, like when I first was told that I was going to start this program, I mean, I'm not a radiologist. I never touched an ultrasound probe in my life, right? And then I get hired and Dr. Shapiro tells me you're going to be doing this, right? But I was like, okay, you know, started reading, started going to all these courses. You start small. The things that I will tell you people can learn quite quickly is the yes/no questions. That's very easy. That's been proven. I mean, I trained my outreach nurses in one session. And then I partnered with them every time they scanned and they were fine. I mean, you pick it up very quickly. You know what I mean? You're like, oh yeah, I see the blood. I see the speckling. I see this. I see that. But the parts that are hard is pediatric scans. Those need expertise. You need training and training and training. And then, you know, for us, I think why our learning curve was so steep and so fast is, you know, when you saw them high-fiving that day, we scanned, I mean, we would scan like 15 patients in a day and a half. And I'm saying like 15 times 6, 90 joints in a day and a half. So when you see 90 normal joints, the abnormal ones will stand out. And whether you like it or not, you develop this ability to distinguish the normal from the abnormal. And then Bruno, Vondrogowski, Rebecca, when we first started 7 years ago, all of us were new to this. So we shared the knowledge, believed in the technology until we developed expertise. Now we're at the point where I would scan someone and then I will call the radiologist and I'll say, hey, FaceTime me, look at this. And he'll say, don't send them down for an ultrasound. I'm not going to be able to tell you anything more than what you just told me. If you still don't have an answer, let's get a CT or an MRI. You see what I'm saying? Because musculoskeletal scanning is very, very specific. Very few people invest in it. And who better to do it than the patients themselves and their providers who are right there and they know their joint disease the best, right?
Right. Mm-hmm.
Yeah.
Makes sense. Any other questions for Dr. Bakeer?
I just have a very quick one. You said that there was a difference in hemophilia B and A. What have you seen?
So, you know, again, these are kind of the things where it's like observations, you know what I mean? And they're subtle. I don't know how to back them up. 8 is a little bit different than 9 in the sense that what we know is that 8 is very important in the collaboration. Von Willebrand 8 and the bone cells, they have to interact. So if you're missing that, your bone modeling, remodeling is defective. So we tend to see different type of involvement of the bone and the cartilage in factor 8 patients compared to factor 9 patients. But that is not speaking of 9 inhibitors or 8 inhibitors. I'm talking pure 8s and 9s. Does that make sense? Yeah. That's kind of what it is. And it has to do with the function of factor 8 compared to the function of factor 9. Yeah. But factor 9 inhibitors, I would say, before concizumab, I mean, they really drew the short stick, I have to say, in hemophilia, because it took forever to bring a therapy for them. But I'm really excited to see what we can do for you.
Yes, me too. Thank you.
Yeah.
Thank you once again, Dr. Bakeer. We really appreciate your time. It's been a pleasure having you enlighten us on this subject.
It's my pleasure. Thank you for everything. And I hope I kind of simplified, a little bit of a tough topic, just to kind of give you a little taste and keep you thirsty for more.
Absolutely. I hope we can partner again.
Yes, absolutely. And send my best to the girls. And you've got some great, great talks coming up.
Thank you very much.
Yep. Take care, you guys.
Thanks, you too.
Bye.